Hello and welcome back to my channel. Today, we are going to talk about a very common medical disorder in pregnancy, which is hyperemesis gravidarum, where we will be discussing the etiology and pathophysiology, risk factors, clinical features, differential diagnosis, investigations, and management. So, what is the meaning of hyperemesis gravidarum? The word emesis means vomiting, hyper means severe, and gravidarum means occurring during pregnancy. It basically means persistent and severe vomiting during pregnancy, which leads to weight loss, dehydration, and electrolyte imbalances. The commonest electrolyte imbalance that can be observed is hypokalemia. Remember this, it is a common question in long case. Diagnosis of hyperemesis gravidarum must meet these criteria: number 1, more than 5% pre-pregnancy weight loss, number 2, dehydration, and finally, electrolyte imbalances. Now, let us discuss the pathophysiology of this disease. In pregnancy, the placenta releases beta-human chorionic gonadotrophin, or also known as HCG hormone. As a result, this hormone level rises rapidly. The high HCG hormone stimulates the chemoreceptor trigger zone in the brainstem. The CTZ feeds into the vomiting center and causes vomiting. Over the years, various other etiological factors have also been proposed, which includes genetics, immunological and biosocial components. There are few risk factors for this condition. Number 1, first pregnancy, number 2, previous history of hyperemesis gravidarum, number 3, raised BMI, number 4, multiple pregnancy, and finally hydatidiform mole. When you suspect hyperemesis gravidarum, you should ask questions like the patient's age, parity and gestation, history of presenting complaint, duration of nausea and or vomiting, frequency of vomiting, oral intake, is there any significant weight loss, and any urinary symptoms. Ask also about her bowel habit, past medical history, history of previous hyperemesis gravidarum in current and previous pregnancies, any previous admissions for this disease, thyroid disease, drug history, antiemetics used. Basically, you are trying to find out the 3 criteria of diagnosis of hyperemesis gravidarum, the risk factors and the differentials. In regards to clinical examination, you need to check the vitals like temperature, pulse, blood pressure, respiratory rate, oxygen saturations. Remember, always look for signs of dehydration like dry mucous membranes and increased skin turgor and any signs of muscle wasting. Don't forget to perform abdominal examination and other examination guided by history. For example, if you suspect thyroid disease, be sure to perform a thyroid examination. When comes to differential diagnosis, any condition that can cause vomiting is a correct answer. I remember a long case of hyperemesis gravidarum when we practicing bedside presentation, the lecturer asked for 20 differentials. So, what I am sharing here is mere tip of the iceberg. The differentials are gastroenteritis, cholecystitis, hepatitis, pancreatitis, chronic H. pylori infection, peptic ulcers, urinary tract infection or pyelonephritis, metabolic conditions like diabetes ketoacidosis, neurological conditions like encephalitis, or even drug-induced can be potential differentials. In hyperemesis gravidarum, the diagnosis is often clinical. However, we can do certain investigations mainly to evaluate the stability of the patient, to evaluate risk factors, and to exclude differentials. Investigations are divided into bedside, lab tests, and imaging. In bedside investigation, you would look for weight and perform a urine dipstick to quantify ketonuria. As far as imaging is concerned, you are looking to confirm viability and gestation, exclude multiple pregnancy and trophoblastic disease. In laboratory test, you should examine midstream urine, do a full blood count to look for anemia, infection, or raised hematocrit. Also do an urea and electrolytes test to look for any electrolyte imbalances, a blood glucose to exclude diabetic ketoacidosis if diabetic. You can also do a liver function tests to exclude liver disease like hepatitis or gallstones, monitor malnutrition, do a serum amylase to exclude pancreatitis, thyroid function tests to look for features of hypo or hyperthyroid, and finally you can do an arterial blood gas to exclude metabolic alkalosis or monitor the severity. Management of hyperemesis gravidarum depends on the severity of the disease. In mild cases, patients should be managed in the community with oral antiemetics, oral hydration, dietary advice and reassurance. In moderate cases, should be managed with ambulatory daycare. This involves intravenous fluids, parenteral antiemetics and thiamine. In severe cases, inpatient management is necessary. If the patient failed to respond to a single antiemetic agent, combination therapy needs to be utilized. As such, the intravenous rehydration should be with 0.9% saline and potassium chloride should be added as guided by electrolyte monitoring. Additional therapies include, to use, H2 receptor antagonists or proton pump inhibitors for reflux, esophagitis or gastritis, thiamine for prolonged vomiting to prevent Wernicke's encephalopathy and thromboprophylaxis for all women requiring admission. Let us go over some of the key points. Hyperemesis gravidarum is diagnosed based on severe, persistent nausea and vomiting leading to dehydration, significant weight loss, and electrolyte imbalances. Second, the clinical features include extreme nausea, dehydration, weight loss over 5%, and possible ketonuria. Thirdly, investigations focus on lab tests for dehydration and electrolyte levels, bedside tests, and ultrasound to rule out other conditions, and finally the management involves rehydration and antiemetics. That's all for this topic. As usual, please give a thumbs up, comment and subscribe if you find this video useful, as this will motivate me into doing more videos like this. Don't forget you can request your biology or medicine topics via the Google form that is linked in the description below. Thank you and see you all in the next video.